So I think the first decision that you need to make is she a candidate for interval cytoreduction? And I've talked about some of the things that one considers there. So having made that decision to not do that and discussing it with the patient in terms of what the relative pros and cons would be as well as the anticipated benefit, you then move to systemic treatment. So you have multiple options today. As our audience probably knows, bevacizumab has been recently approved for platinum-sensitive disease. So this is an opportunity here to use this. There's several things that really, I think, make me interested in using bevacizumab. And one of the primary things is that she has ascites and she's symptomatic from that. So you have multiple options in terms of what one could do. Most people would use certainly platinum at this point, being that it is platinum-sensitive disease and it would be considered to be highly platinum-sensitive, being that the time interval is almost 2 years out for her. When you pair something with platinum, you have multiple choices. There's literature looking at paclitaxel. There's also literature looking at pegylated liposomal doxorubicin as well as gemcitabine. If you bring bevacizumab into the mix, there's been 2 phase 3 trials that have looked at the use of incorporating bevacizumab in platinum-sensitive patients. First one's GOG 213, which is also interesting because you had a surgical component with this trial, so it was basically a bifactorial design where you make a decision if the patient's a candidate for surgery or not, and if they are, they then get randomized to surgery or not. And then you have the decision as to whether they would go on bevacizumab along with the carboplatin paclitaxel backbone. And so this was a fairly large trial with an endpoint of overall survival that showed an advantage for those patients that were treated with the bevacizumab until progression. You also have a second phase 3 trial where platinum was paired with gemcitabine plus or minus bevacizumab. And I think, again, a little bit different in the construct of the trial in that the endpoint for this trial, the primary endpoint was progression-free survival. Saw about a 4-month advantage in progression-free survival with a hazard ratio that was 0.46. So very good response that was seen. The other thing that's really important when you look at these patients and try to figure out whether you want to incorporate bevacizumab or not is the actual response rate. So this lady comes back into your office and she's symptomatic. So that's a patient who you really do want to see an objective response rather quickly. This is a lady who's going to be calling you about inability to eat, and if she has problems further on here, she could have an impending bowel obstruction down the road. Fortunately, she did not have any signs of that, which would be important in terms of making her a candidate for bevacizumab. So I think it's important to look at that because the data from both of these phase 3 trials show a significantly higher response rate if bevacizumab is added. So it's about 78% if you have bevacizumab, and it's about 56% or so if you don't have bevacizumab. So you significantly increase the response rate, which is something that's important in a patient with this profile. The other thing to consider is her BRCA status, because that gets into the potential spectrum of choices at this point as well. So knowing her BRCA status, it would also be important with the new approvals of PARP inhibitors. Yeah, so the platinum-free interval is very important in terms of predicting how a patient is likely to respond to a platinum-based therapy. And so what we've really done is we've broken patients up into those that fail within 6 months of having received platinum, and we characterize those patients as being platinum resistant. If it's more than 6 months, they're considered to be platinum sensitive. Now, many people will subdivide the platinum-sensitive patients into those that recur between 6 and 12 months and call those intermediately platinum-sensitive or partially platinum-sensitive, and then call those who recur after 12 months highly platinum-sensitive. So, again, it's a spectrum, and one needs to recognize if someone's 6 months and a day out, they're probably not going to behave all that much differently than someone who's platinum-resistant. Versus someone who recurs, as in this patient, almost 2 years out, they are likely to be highly platinum sensitive. And the prognosis that's associated with that platinum-free interval is very strong. So the further out you go, it's a continuous variable, the chances of responding become greater.